I'm Alice Park, Senior Health Correspondent for TIME, and it's my pleasure to welcome Dr. Robert Redfield, Director of the U.S. Centers for Disease Control and Prevention, which we all know as the CDC. Dr. Redfield, thank you for joining us for this TIME100 Talks.
Thank you, Alice. Glad to be here.
We're seeing states all over the country now start to reopen. What, in your mind, are the most important criteria that these states need to consider as they start reopening and as we have people now mingling back together after being in this period of lockdown?
Well, when we originally put out the guidance for reopening America again, there were several features that we believe were really important. The first was 14 consecutive days of decreased cases in the community, in the jurisdiction. The second was a 14-day progressive decrease in the percentage of tests that are done that were positive for COVID. The third was to have adequate testing capacity for readily available testing, and then to be building the contact tracing ability so that they could have effective contact tracing. These core elements of early diagnosis, isolation, contact tracing, really critical to have them in place. The other aspect of it is the continued embracement of the social mitigation strategies that we have really recognized as our key weapons against this virus right now. That is 6 feet distancing, wearing face coverings, good hand hygiene, obviously staying home if you're sick. The big challenge, as you know, Alice, is that this viral infection can actually cause substantial infection without any symptoms at all. And a significant number of individuals that may be infected may not have symptoms, maybe as from 20 to as high as 80% of individuals could be asymptomatic. So these social mitigation strategies are also important, together with the decreased number of cases, decreased percent positive, making sure that they have testing capacity, make sure they have hospital resilience, and they make sure that they're building their contact tracing capacity.
And even with these guidelines, in terms of the number of cases, we are now at the same level where we were at the peak of the pandemic about a month and a half ago. And in some states that have reopened, Texas, Florida, Arizona, for example, we're seeing that resurgence along with an uptick in hospitalizations, which means that it's just not that we're picking up more cases with testing. Does that tell you that these states reopen too soon?
Well, Alice, I think we always expected to see cases to increase as we reopened. Clearly, the mitigation that the American public engaged in March, April, May, really congratulate the American public. I think we did protect a lot of vulnerable people because of the aggressive mitigation that we did. So as we reopened, we expect to see more cases. We'd like to see those cases early identified and contact trace and isolated around them so that we can prevent sustained community spread. And, you know, that is the big challenge. As you mentioned, currently we have an increased number of cases. We have, I think, even 11 states that have increased hospitalizations right now. We continue to see the net consequences of this outbreak decrease. That is, in terms of mortality. I think the last 2 weeks average mortality rate was we had around 650 individuals. So that's continuing to come down. That's an important advance in that consequence. And obviously the other consequence is reopening the economy and letting individuals begin to get back to work and their employment. So we continue to deploy CDC rapid response teams to the different health departments that are seeing these increased cases. They're not really statewide. And it's a little misleading sometimes when we see the big maps that are all filled in with different colors. It's better to look at it at the jurisdiction level, at the individual county level. But we do have, over 100 counties right now that we consider hotspots. To put that in perspective, that's about 3% of the counties in America are experiencing higher transmission rates than we would like to see, and we're putting public health teams into those jurisdictions, supporting the state, local, tribal, territorial health departments to try to understand what's the source of that community spread, is it an outbreak, and how to basically contain it. I might comment that, recently we saw, for example, Alabama and North Carolina have significant increases. We launched teams to go in and work alongside with the local health departments. And both of those states now are back down. So I think we're going to continue to see this, where there'll be individual jurisdictions that are going to increase. That's going to make an impact on the reporting from that area. And then we need to go in and try to find root causes and bring those that community transmission under control.
And the CDC, one of its roles is to advise state and local health departments. Would you advise them to impose travel restrictions between states, for example, where cases are rising, to really prevent kind of a nationwide resurgence in coming months?
Alice, each state's going to have to make their own decisions. Personally, I'm not one that feels that's going to be an effective strategy for us right now. I am one to really stress the social distancing that I just discussed, of wearing face coverings, hand washing, etc. I did notice today that a number of states have decided to put more restrictions. We did it when the outbreak was really out of control in New York. We recommended that individuals coming out of New York stay self-quarantine. So I think it's an individual decision by the states, and I respect their public health decisions.
Okay. You've said before that you're worried about the combination of flu and COVID-19 in the fall and winter. And recently you testified to Congress that Americans should get their flu shot because next season's influenza illness will occur simultaneously, potentially, with COVID-19. What does the latest science show us about how influenza and COVID-19 could possibly interact, and what should we expect?
Thank you, Alice. I think this is one of the most important things we can do to prepare for the fall and winter that we're going to experience. And the real risk is that we're going to have two circulating respiratory pathogens at the same time. We know flu by itself can cause substantial morbidity, mortality, and hospital utilization in our nation. In some jurisdictions, flu itself can bring hospitals into great stress situations. And then you combine that with the recurrence of or the continuation and expansion of COVID-19 during the fall and winter. This could be really a very, very difficult situation. This is one of the reasons I've really asked the American public to really embrace flu vaccination with confidence. This single act is going to save lives. As we sit here, historically, less than half of the American people get flu vaccine. Many people don't realize that flu can cause substantial mortality. More than 360,000 people died from flu in the last decade. So we have a vaccine that can prevent death and illness and infection in influenza. And as I said, with less than 50% of people accepting the vaccine, this is a year that I'm asking the American public to seriously reconsider, because that decision may make available a hospital bed for somebody else that really needs it for COVID. So I think it's really important. We're hoping that we're going to be able to get significant more of the American public to embrace it. Clearly, these two viruses are very capable of causing significant morbidity and mortality, particularly in those who are elderly and have underlying medical conditions.
You've emphasized the importance of testing to ensure that we keep a handle on this pandemic, especially as people start emerging from isolation. But just a few days ago, the Trump administration officials reported that they were going to pull federal funding for testing sites across the country, including in Texas, where we're seeing an uptick in cases. Have you and will you speak to the president to reiterate the importance of testing?
Testing is really a critical component, as I said, readily available with timely results, so those results are actionable. the decisions on the testing sites that you mentioned, there were 13 of them that were transitioned into our community health centers. The remainder ones that were discussed potentially of closing, they're going to remain open at least for the next 60 days. So testing is a fundamental requirement. We at CDC are also going to be expanding testing for what we call surveillance, because so many people are asymptomatically infected. The only way we know that if the virus is in some different communities is if we actually do proactive surveillance. Congress has provided to CDC substantial resources, of which $10.25 billion, $10.25 billion were made available for CDC to give to the states to build their testing strategies, contact tracing strategies, isolation strategies. CDC has already given those resources to the states. The states have developed plans which have been reviewed, at least for the month of June and July. And then in July 15th, their plans for the rest of the year. Getting those new resources to the states to make sure they have robust testing is fundamental to our ability to stay ahead of this outbreak. So this is not a time to decrease testing. We have made enormous improvements in the availability of testing, but we still have a ways to go till we get to the testing availability that I believe will be necessary to have us stay ahead of this outbreak in the fall and the winter.
And do you feel any pushback to that? I think, all public health leaders agree that testing is going to be crucial, as we go into the fall. But has there been any political pushback to being able to keep that network and keep those programs going?
No, I think the truth is, I think that there continues to be high interest in us continuing to expand. I think as of today, the United States tested, 29,300,000 individuals. As I mentioned, we're now testing 500,000, 600,000 a day. But I don't want to stop there. I think we still need expanded testing readily available throughout each jurisdiction in this country. It is going to be the underpinning of our response, coupled with, as I mentioned, the contact tracing. It's worth to take a minute on contact tracing. In January, our nation had about 6,000 contact tracers in the health departments across this nation. As of June 2nd, it was reported now that's up to almost 28,000. I've estimated that we're going to need close to 100,000. My predecessor, Tom Friedman's estimated it might be as high as 300,000. But we are going to continue to work with the states in the month of June and July to get those contact tracers up really in the range of, they estimate they need about 78,000 when we've polled them all. But we're going to need to get it up to that range of between 80 and 100,000 at least to be prepared. But that in itself isn't going to help us if we don't have readily available expansive testing.
And some of your predecessors, former heads of the CDC, have used words such as greatly concerned and surprised that the CDC just isn't more visible in informing the public about the changing situation with COVID-19. And some leaders have even suggested that the CDC has been sidelined during this pandemic. For example, the White House held up your agency's proposal for how to reopen America. Has the CDC been sidelined when it would normally be taking a more visible role in guiding the country through this pandemic?
Alice, I'd say no. A couple things I would say. First, we have a seat at the table in the task force where I represent CDC for many, many, many months. It was every single day, 7 days a week. Now the task force meets several times a week. So we're representing our views. And I can tell you those views are heard and those views are respected. Secondly, we've reached out to the American public. Right? We've put out more than 1,500 guidance documents and consideration documents from CDC. We continue to post them regularly. We've had over 1.5 billion hits on our website to download those documents and read those documents. We have conferences with the state, local, tribal, territorial health departments multiple times during the week. We're having interactions at that level. We're having interactions with special communities, whether it's faith, business, school, higher education to share our guidance directly with them. So we continue to be quite visible, I think, at the local, state, and local territorial level. And we will continue to try to expand our opportunity to communicate more directly to the media and the leaders like yourself to get the words out more directly as we get those opportunities.
Okay. And you mentioned the White House Coronavirus Task Force, and the White House recently released its list of 5 vaccine candidates that would be part of Operation Warp Speed. You know, that would mean they would receive funding and support to continue their development. Were you part of the discussions on the selection of those 5 candidates?
Yes, I'm on the board of Operation Warp Speed. So we're one of the members of the board.
And do you feel the scientific perspective was there pretty much consensus agreement on those 5 candidates that were selected?
I think there were excellent criteria that was developed, because one of the major criteria for consideration of all the different candidates that were looked at was there the capability of actually manufacturing that vaccine and having it available by the end of 2020, beginning of 2021. So of the initial 5 candidates that have been selected for acceleration, and when we talk about warp speed, the speed is not to take any shortcuts with safety of the vaccine or even the scientific integrity of the process. The speed is really around taking financial risk. Normally, when we develop a vaccine, you do a phase 1 trial. If it looks good, you do a phase 2 trial. If it looks good, you do a phase 3 trial. If that trial shows efficacy, you may or may not have to do another phase 3 trial. Then when you have evidence that you have efficacy and the FDA recommends approval, then you go figure out how to make enough to give to people. What we're doing in this situation is, as these vaccines go into phase 3, and we should have several vaccines into phase 3 trial before the end of July, that the commitment will be made to manufacture that vaccine in order to have at least 100 million doses, so that if it works, we have the vaccine at that moment in time. I want the American public to realize Tony Fauci and I aren't big fans of the word warp speed, because people think we're skipping steps. We're not skipping steps. The only real risk here is financial. So the candidates that were selected were the ones that had the best evidence from preclinical data and had the capability of actually being able to meet the manufacturing goal of being available by January 2021. There's additional candidates that will come along behind it that may be available later in 2021 and 2022. But these candidates were also selected for the mission, which was to have vaccines available for the American public by January 2021.
And from what you've seen, since you were on the board and sort of looked at the data that the companies have so far in their plan moving forward, how realistic is it that we can expect a vaccine, toward the end of this year, beginning of next year?
Well, I think if you'd asked me that question 12 weeks ago, I would say it was highly optimistic. If you ask me that question now, I think there's a real probability that we're going to accomplish that. No one can guarantee it, but the amount of progress that's been made in recent weeks is substantial. So I think if you were to ask most of us, myself, Tony, and others, I think right now we think this is a realistic goal, and I think we really do have a real good chance of having a vaccine available, one or more vaccines available before January 20.
Okay, and finally, just wanted to ask you, looking back with 2020 hindsight, was there anything you would have done differently in terms of handling the pandemic toward the beginning of the year, January, as the cases were starting to appear here in the U.S.?
Alice, it's an important question, and I think we're going to have, lots of reflections when we get through this and get this pandemic behind us, which I'm confident we will. I think the first thing that I think I wish had been different, whether I could have made it different or others could have. I wish that the American CDC was invited in to work alongside my Chinese colleagues when I asked on January 3rd to send teams in to assist them, and formally wrote a letter on January 6th asking my colleagues, who I have a lot of respect for, to allow CDC to send individuals in to help. Because if we had done that, I think we would have learned more quickly that the initial assumption that this wasn't transmitted human to human was obviously not correct. It is transmitted to human to human. The second thing that I think we would have learned quicker is that not only is it transmitted human to human, but it can be asymptomatic and asymptomatically transmitted human to human. I think those two scientific understandings, because when we were looking at this initially, it was thought by our Chinese colleagues that this was not transmitted human to human, it was animal to human, and there weren't secondary cases. And it was taught that it was a symptomatic illness, and we didn't understand the scope. So those scientific realities, I would have really loved to had a handle on. The other area that I think I would have, if I had 20/20 hindsight, is I think it would have been useful if we had gotten the private sector engaged earlier in January to help with the diagnostics. Clearly, CDC did its job. I think we've gotten unfairly criticized because people didn't realize what our job was. Our job was to develop a test for the public health laboratories of this country, which we did, and we did it in record time. And that test was always available, was never flawed. When CDC decided to further manufacture that test, to give that test to be able, each lab to do it itself across the country, we had a manufacturing contamination, which we had to take the next 3 to 5 weeks to figure out and replace. If I did it again, we would have a manufacturer manufacture the kit. But most importantly, I would have gotten the private sector involved to be making test kits for the hospital and for clinical medicine. And the private sector stayed on the sidelines because they developed these tests for SARS and no one needed to use them. Then they developed them for MERS and no one needed to do them. So I think if I had a do-over, I would get the private sector making these tests back in January, the same time CDC was making the public health tests. So we would have had expanded availability of the private sector to provide testing. Those are probably a couple of the things that I think would have had an enormous impact, particularly getting the scientific information. If CDC and WHO had been invited into China, the first week of January, I think the world would have had a better understanding of this pandemic going into February, and we could have put that knowledge into action.
I just wanted to go back to that then. My understanding is, so CDC does have a team, right, in China that's permanently based there and works regularly with scientists and health officials in that country, right? So it's a matter of being invited by the Ministry of Health and researchers there to participate and sort of, I guess, share the research that's available, right?
That's right. CDC has people in about 60 countries around the world, including China. And we've had a long positive relationship with our Chinese colleagues. And I actually have a U.S.-China CDC co-located with the China CDC, the Chinese CDC. And we work together on flu and respiratory viruses and a variety of diseases. Our footprint has been smaller as funding was curtailed in several years ago. But now, in the last year and a half, I've been augmenting that footprint because I think it's really important to maintain that. When it came to this particular outbreak, there was not our American CDC in China, they were not brought in to work with the Chinese CDC on this outbreak. And I wanted to augment.
Why was that?
Well,
was that unusual to not be invited?
Yeah, I think it was unusual. It was not a decision made by the Chinese CDC. And I had rostered a number of individuals that were prepared to go assist. I assumed when I talked to my counterpart in China on January 3rd, I assumed that we were going to be invited to put our teams in because we've never been not invited. And so I had rostered teams ready to go of experts to go assist. And unfortunately, we were not invited. And even when the WHO brought their team in, which was very restricted, the United States only got 2 individuals on that team, and CDC only got 1 individual on that team. But we were prepared to put 20, 30 people into the country to really help get a handle on this outbreak right away. And, I'm confident it wasn't the decision made at my counterparts level. And I don't know why China decided not to take advantage of the help that we offered. But we will continue to offer that help, and we will continue to try to build our partnership with China in our China CDC, as we will with the other countries around the world where I have full-time people deployed to work in partnership with the local health departments in those nations.
And how is the collaboration with the Chinese scientists and Chinese CDC now between the U.S. CDC and the China CDC?
I think it's good. We continue to work on some very important areas. As I say, we've had a long history of working together on influenza and some influenza surveillance. So we have a long history of working on emerging pathogens. I have a country director there, and scientists come join that team full time to live in China, and so we're augmenting our China footprint as we speak.
Dr. Redfield, thank you so much for joining us. We really appreciate your time, and thank you for your work and the work of the CDC in guiding the country through this pandemic.
Well, thank you too. I appreciate it. God bless.